I think that there are a couple different areas that we could address in that regard, and the groups, I would say number one would be patients that have IDH1 or IDH2 mutations, and this is somewhere around 20% of patients. There's drugs that inhibit each of these mutated enzymes that are quite effective. Not effective enough for everybody. I think there's still a long way to go before we feel like we have truly effective therapy for the disease. But these work in about a third, 30-40% of patients as monotherapy. But it looks like increasingly that adding them to chemotherapy is going to be the way to go to really substantially increase the response rate. So that's IDH1 and 2, monotherapy, and then combinations with less intensive therapy, potentially combinations with intensive chemotherapy. Another category would be inhibitors of FLT3. There are two that are now FDA approved. One of them is called midostaurin. It was approved first as a drug in combination with chemotherapy, and it looks like it improves survival, reduces relapse. Seems like transplant is still an important component of activity there. That so the idea is to get patients to transplant and then potentially maintain them afterwards, although that still remains to be clarified. And then more recently, a drug called gilteritinib was FDA approved as a single agent for patients with relapse disease. And I think what we're going to see with gilteritinib is quite likely anyway going to be combinations with chemotherapy, again, both intensive and less intensive, but that remains to be sort of sorted out to see exactly how it goes forward.